Welcome to the SNF Spotlight Series. I'm your host, Yitz Rubin, and in this series we will be speaking to some of the healthcare leaders who are making a big impact in the industry. Join us as we shed light on a variety of topics that will benefit both our SNF colleagues as well as the general public. So Ruthie, I wanted to jump right in. You had contacted the SNF Spotlight Series because you had seen Eric Klein on the show. Mm-hmm. Can you tell me what made you prompt to say, hey, I also wanted to be on the SNF Spotlight?
Well, Eric and I are partners. So he owns CarePatrol Chicagoland North. I own CarePatrol Chicagoland South. And I think that, he did such a great job of selling CarePatrol and what we do and who we are. But I think there's so much more that there wasn't enough time for him to cover everything. And I think that for us, there's just so much more awareness and education that we can give to help people get exactly what they need,
Yeah. I've noticed you're very passionate about what you do. Originally started as a nurse. Can you give me a little bit of a background about what made you become a nurse?
Sure. So, I think the generic answer would be because I wanted to help people and take care of people. But I'm a true believer that your life experiences kind of shape your future. And when I was 16, I was diagnosed with a lethal cardiac arrhythmia, and the prognosis was really grim. And while doctors were trying to help me, I also found myself being researched and kind of getting put in places that might not be the best for me, but could help them further the cause of science. And I had a nurse that stood in for me and said, no, we're not doing this, and went to the head of the department because I was scheduled to have another procedure, and he said, this is unethical. And the head of the department shut it down immediately. And I obviously didn't go back to that doctor. So I went to another doctor at another hospital, kind of went up a level. And this nurse walked in, I was on the procedure table, and I just had tears streaming down my face because they had actually overstimulated my heart and killed me on the table, and had to bring me back. And at 16, I remembered everything. I was supposed to be sedated, but I remembered the whole thing. So I was really traumatized. And this nurse grabbed my hand and he said, I'm going to hold your hand through this whole thing. I know your case, and you're not dying on me today. And that was what I needed to hear, because he was able to identify what no one else could. I was scared to death that I was going to die because that's what everybody was telling me. And when I would get on the tables, that's what would happen. So ironically, I didn't die that day. As I later found out, his brother was the one at the other hospital that went to bat for me. And because he went home that night and told his brother all about what happened, he knew exactly that it was me. So it was kind of cool to have a family come and take care and advocate for me. And I think now I can see that as a nurse, that we never stop working. We don't. If it's our neighbors, if it's our friends, they ask us everything. We're their lifeline. You get your RN and that's it. You're everybody's go-to.
So you went through a trauma yourself as a child, and the terrifying trauma. Mm-hmm. That made you now come in and say, hey, let me care for the elderly, mm-hmm. and take care of them the way that I would have wanted to be taken care of. Yeah,
I think, so for me, I worked with the geriatric population when I was when I was floor nursing. So, I got a special place for them in my heart. And I had some back surgery, so I wasn't able to go back to floor nursing. So when I found CarePatrol, it kind of jived with my mission, I feel, and how I'm supposed to help people. And I had taken care of my mother-in-law. She had a stroke. She was paralyzed, feeding tubes. She didn't have the resources to go into, one of the nicer places. So I brought her home. I cared for my own mom, who had dementia for 5 years. So I've been in the shoes of the people out there. And I think that makes them more comfortable, because it's not just a professional telling them why they have to do things, how they have to do it. I've lived it. So it also helps me identify when people are really in crisis.
So tell me a little bit about morals and ethics within the medical field.
Overall, I think people are in this for the right reason, and they genuinely want to take care of people and do right by them. But sometimes the system itself breaks, and maybe it's an insurance thing, and I think there's a lot of doctors out there that would like to do a lot of things that they can't do because insurance guidelines won't allow it. I think with COVID, we've completely crossed boundaries and barriers and gone into uncharted territories, and some of that is good and some of that is not so good.
In what way? How did we go? Which boundaries did we cross?
Well, I think it was just a whole new thing that we had never experienced. So I think some of this, I mean, it was uncontrollable. It was a matter of funding. It was a matter of supply versus demand. But I know a lot of our nurses, they were wearing the same masks for hours. And you go back to our ethics and our morals and all of those things. I mean, we know what sterile technique is. We know what proper protocol is when we're going into an infectious situation. And there was compromise being made there. And I think at some point the caregivers themselves, the healthcare providers, were being put in jeopardy over this. And unfortunately, so were their families. So I think that we lost sight of that, hey, we're here to help, but you also got to take care of us a little bit in this too.
Yeah, absolutely.
You know? And I just, that's the part that bothered me. And I think something that we're seeing in the industry now is there is a big caregiver shortage out there. During COVID, I think that a lot of them were asking for more money. They were asking for a lot of things. This was all hands on deck, right? We had never been through anything like this. And for me, it was very difficult because I knew my friends at the hospital were not getting a dime more and were working 10 times as hard. And I just felt like we're in this together. Like, this isn't about the money. This is about survival at this point. And you have to have the compassion to do this job. And if you don't have it, don't get into it. Because you came into this knowing you were going to be exposed to different viruses and bacterias. It's kind of the expectation.
It's like you're on the front lines. For example, if somebody goes into the Army, they're going into the front lines. That's part of the job.
Right.
So this, unfortunately, the nurses, your peers and colleagues were going through this.
Absolutely, and I think that's a great way to talk about that and, you know, to refer to that, because, I mean, people sign up for the Army, but they don't necessarily want to go into combat. But that's out of their hands. It's a possibility when you do it, and I think that's the same thing for people that get into healthcare. It's scary, and nobody wants to do it, and people could come back and say, well, did you go out there on the front line? And I was asked to go back to the hospital, but for personal reasons, I lost my husband a year ago, so I couldn't do that and leave my 14-year-old without a mom. It would have been irresponsible. But had he been here, I would have jumped right in.
Wow. Sorry to hear about your husband.
Oh, thanks.
Sorry for your loss. Tell me more about CarePatrol and how you handled this with your patients.
It seemed like things would go in spurts. You know, maybe there would be a little tease that things were going to start opening up. And, you know, I had a family that was out in Delaware, and the mom was in an independent living, and the daughter just wanted to get her back here. And we went out, you know, kind of did our intake situation from, you know, over faxing things and submitting the clinical. And she just wanted to get her to Chicago and get her moved in. And I had to kind of say, okay, but wait a minute, she's already in an independent living. Then we're going to get her on a plane, and then we're going to move her into another community. We can't do that. That's 3 points of possible infection. Like, we can't. So we've got to leave her where she's at right now, and you just got to trust me that as soon as it's safe, we'll do this. But I'm sure somebody would have probably made this happen. But I wanted to make sure her mom got here safely, because if her mom got here and got sick, that I would have felt horrible. So it's just teaching that. I mean, you have to ask people for their trust, right? Which is really hard, because it's hard to ask for help from people that we know, our friends and family. It's 10 times harder to ask for help from a stranger, because you don't trust them. So, you know, I have a very short span to earn that trust. And I think that, you know, with CarePatrol during a pandemic, we just had to rise to the challenge of doing what was best and advocating for them like we do every day, and not letting that change or any variation in it. You know, I think that still involved me going, you know, talking to these communities. What are you doing to keep your residents safe? How can we bring new people in? You know, we stayed on top of those things so that there wasn't a lot of communities I was moving anybody into, because I knew of maybe 2 that had really raised the bar with their protocols, and I felt comfortable bringing my people there. Because one thing about me, if I don't feel comfortable, it's not going to happen.
So what were they doing differently?
So the one, ironically, it was their structure, right? The way that their building was designed. And they had 5 different buildings. So that was a lot easier for them to keep the quarantine at where it needed to be. But the director of nursing, who I think is one of the best out there, decided that he would shut down one building and move everybody out and have that be the building where all the patients from the hospital were coming, or the patients from the SNFs, the skilled nursings, were coming because they needed to do their 10-day quarantine. So they took a couple of the rooms, they put the plastic up, the zippers. If they knew that they tested positive, then they would gown up and, do the proper protocols for that. But then if they were, still doing their 10-day quarantine, but they were testing negative so far, they were in the front side of the building. And then once the 10 days were up, they were still negative. Everything would get washed. The clients would get showered. They would go over to one of the other buildings where the families would have brought the stuff, and the community had the maintenance guys sanitizing everything. All the clothes were washed, and they were literally showered again when they got into that next building. So there was like a lot of infection control. I've seen some of the communities that had infection control nurses in there, which I think was very good, because you need the experts to come out and help you in what you don't know.
Right? Absolutely. Also, now we're in June, the beginning of June 2021. Would you say that things have eased off and nurses and the medical field are prepared for COVID, and it's a lot safer now for the elderly to maybe go into a skilled nursing facility, assisted living?
So I think we know a lot more than what we did when this first rolled out. I mean, when it first rolled out, it was about containment and, saving lives. And I think as time's gone on, we've learned a lot. And I think that it's safer to go into a skilled nursing. I think we've got to help the caregiver shortage that's going on, because the staffing, across the board is something that we need to tackle. I think a lot of the caregivers got spooked, rightfully so. I mean, our country just went through something we haven't gone through since 1912 or 14, something like that.
I was a young boy at that time.
Yeah, were you? Me too. Yeah. Toddler. We look great for that age, don't we?
Thank you.
I think things are definitely looking up, but I think this is the downside of it right now is the shortage in the caregivers and the strain.
So how does the aspect of finance affect the caregiving?
So one of the hardest things that we run into is people just can't afford the care that their loved ones need a lot of the time. So, we can help them identify, some of the resources that might be available if they're eligible for certain things. But I think it goes on farther than that, is that a lot of times we're in the situation where, we're getting these calls and it's a spousal situation, right? And let's just say the wife is taking care of the husband who is declining, and the wife is getting burned out, and she doesn't want to, move him anywhere because then the guilt comes back, right? And so she's, going along and, she's getting burned out, and statistically we know that the caregivers can end up with their own health crisis and sometimes even pass away before the actual person that they're taking care of. When we get these calls, we have to have those difficult conversations, but then it comes to the next level of, okay, now we have a couple where most likely their monies are kind of flooded together, right? And we're going to need some of that to take care of dad. But we got to make sure that there's enough money to take care of mom. So that's bringing in the elder care attorneys and making sure that their portfolio is set up and things like that. I think one of the biggest misconceptions out there that people think is that Medicare is going to pay for assisted living. Assisted living, your private duty caregivers, those are all out of your pocket. There's no Medicare involved in that.
So would you say that typically skilled nursing facilities are a better option for someone who's financially strapped?
Sometimes it's the only option. I think that's during the pandemic, what was also difficult for me is because people were being labeled as having conditions that maybe they didn't have because the education wasn't out there. There's a lot of people that are in the long-term cares, which is the other side of the skilled, simply because they don't have the resources to pay for assisted living. It's not necessarily that their health requires it. They have something, but maybe it's not as advanced as needing that kind of care, but they simply can't afford it, so it's the only option. Does that make sense?
Yeah, absolutely. So it sounds like because I've been hearing a lot that a lot of people are going to be shifting because skilled nursing facilities didn't have the best name over the pandemic, not necessarily to their detriment. How would you address that stigma of nursing homes having that bad rep?
So I think first of all, the nursing homes have to address. Obviously, they know that the bad rep is out there, but they got to figure out how they're going to address that to fix it around. And I will always tell you, it doesn't matter what spectrum of care you're talking about. Care is the most important thing. If you deliver it, they will come. If you don't deliver it, they're not coming. And what's the old saying? If you do something right, it takes how long for somebody to hear about it? But if you do something wrong, everybody knows about it in 10 minutes. And, I think that the population is getting, smarter about going to cms.gov and looking at the ratings. But I always caution people, like, they're going on Google review, and you can't tell anything about a community by that, for the simple reason you don't know the situation by a Google review. You don't know the situation by all of these ratings that you're looking at. Was the person accurately placed in the right skill set? Did the skill set fail because they were where they didn't belong, or did it fail because of staffing? Like, it's such a complex issue. And I deal with this all day long with my assisted living people, and it crosses with the assisted living and the skilled. Like I kind of said earlier, we go to our friends, our family, we tell them what's going on in our lives, and they say, oh, we'll try this place. So-and-so had a great experience there. And before I know it, I'm getting bombarded with phone calls, emails. Hey, so-and-so said, check this one out, check that one out. And it's like, okay, but it's not the right skill set. And I think, obviously our friends and our family, unless they're in the medical profession or, a placement agent or something like that, they don't have the knowledge to know exactly where you need to go. So while I think it's important to have those, the name dropping and the positive experiences, it just makes our job harder, because it's like, okay, well, that's a skilled nursing. They're going there for rehab, and then they're going to have to either transition to long-term care, or we're going to have to bring them home with home care, or we're going to have to place them in assisted living, or maybe in the VA home. I mean, there's options, but we've got to assess that whole thing and see where it's at.
Right.
So it's just, I think that's the benefit of working with a senior advisor, is because that's what we specialize in. This is our business, and we know that, but we also understand that people are scared.
So is this why you got in with your clinical background? Is this specifically why you got into the space of helping the elderly?
Mm-hmm. So when I bought CarePatrol, I had been in such a long stretch with my back and my surgeries and stuff, and I just was like I told you earlier, I feel like life experiences plan your future. And I would just sit there and be like, why did you take away my career? Why did you take away everything that I loved out of life? What am I supposed to do with this? And it was between buying CarePatrol and buying a home health agency. And I'm like, I can't do that, because I know me. I will be giving somebody a bath because they need it, to the detriment of myself, but they'll be okay. I can't do that, because, again, even then I knew the caregiver rollover and the staffing, it was going to be the same for me as it is for everybody else. So CarePatrol was great because it allowed me to bring my clinical into my business, to use it to benefit my seniors. And I think that the healthcare system sometimes fails people. It doesn't mean to. Maybe it's an oversight. I'm just another pair of eyes. There's times I walk in to go see a patient in the hospital, and they're eating a muffin, and I go get a swallow eval done, because it doesn't help me do my job if I don't know that, because maybe I move them into a community that can't puree their diet. Well, now that family's out a whole lot of money because I just moved them in the wrong community. And I think that's something that CarePatrol is very proud of, is our move-in rates, because we don't want people moving out. I take that, just for me personally, I take that very personally, because it means I didn't get it right, which isn't necessarily true. It can be I'm not responsible for the care in there, but that's how personally I take it.
Right. So you're a real advocate.
Oh, yeah.
So talk to me about the difference between physical, emotional, and mental care.
Physical, to me, would be your ability to ambulate, your ability to use your hands. Do you have the dexterity to make a meal? Can you physically get yourself to the shower? Bed transfers, chair transfers. How mobile can you be? And then when you get into the emotional and mental, which to me would kind of be grouped as psychological, how is your day? How are you feeling about your disease, prognosis, your diagnosis, how you're progressing, your deficits, what are your fears? And just overall, how are you doing today? And just kind of accurately gauging that, because it's your overall well-being. How are you doing today? There's a lot in that sentence. And I think that that's something that we always need to be on top of. So one of the things that I'm doing now when I'm out in my communities is I am a big advocate of, we need to get these seniors in physical therapy. They have had a year of isolation, whether it was home, whether it was in skilled, whether it was in long-term, whether it was in assisted living. Therapy was happening, but it was very condensed. and we need to get them moving again because we owe them their independence. As much as they can possibly do, we need to support them and give them the resources to have that independence. You know, we're going out, we're encouraging that we're getting physical therapy, and then on the other side, I'm also going out and I'm encouraging, are we assessing their mental health? Because they've been isolated, they've been away from their families. Many of them lost loved ones and didn't even get to say goodbye, didn't get to be there at the end. And that goes on to the families as well. We had a lot of families that didn't get to say goodbye to their parents, that didn't get to be there in the end. And I think we as a society have a health crisis coming that no one is ready for. Because there's a lot of guilt, there's a lot of shame, there's a lot of hurt. Not everybody gets the opportunity to say goodbye to their loved one. But we have all these resources to allow that to happen, and we need to focus on that. So, you know, having the psych consults brought into them to really accurately assess how's that person doing today. And I think we need to remember that generation has the stigma of mental health. They are not going to tell you they are depressed. We have to look for the silent cues to be able to help get the help that they need. And I think the two together work well because medicine is not always the best answer for depression. We know that exercise, sunlight, engaging can also do those things too.
Yeah.
So it's an intricate balance.
Would you say this can also be done through groups, like
Absolutely.
walking together or, you know, going to the park, doing yoga?
Yes.
So
Absolutely.
So this would be not just helping them physically, but also emotionally.
Absolutely. And I think, you know, now that most of the communities have the residents vaccinated, you know, the activities are, you know, back taking place, and, you know, they could take them out and do yoga outside, get the vitamin D going, and, you know, they haven't been out in so long. Like, let them live. You know, I was out the other day and they were just so happy to be sitting outside in the sun. I mean, they were happy. They've been happy in a year, and it's so good to see, but it's like, let's keep it going because, you know, sometimes you get a burst of energy and then you lose it, right? So we got to keep it going. We got to keep the wheel spinning.
So Ruthie, let me ask you a question. Okay. How are you feeling today?
I'm feeling fine. You know, I was nervous to come and do this, of course, but it's just my passion. Like if me coming up here can help somebody else, I got to do it, even if it means being a little uncomfortable. And I think that that's where our society needs to learn now, is that it's okay to not be okay. It's okay to not feel your best, and it's okay to ask for help. Right. And it's okay to be uncomfortable. And I would be a hypocrite if I wasn't willing to put myself out there to be uncomfortable, but I'm expecting my families to do that.
Right, absolutely, because the natural human instinct when somebody asks someone, hey, how are you? They just say, I'm fine, I'm great.
Yep. And that's what our seniors do. And that's what they tell the docs. So that's what they tell the nurse practitioners. And a lot of times they know that that's not the case. But I think, you know, we need to remember that family has a lot of information. Use it. I thought today maybe 5 to 10% of my calls are from the actual client. It's not. It's from their spouse, from their family, from a concerned friend, from the hospital, from, you know, the SNF saying, like, they can't go home alone. They can't do this. So somebody's advocating on their behalf. You know, we got to remember to include those people. But when we're talking to them, we just listen, because they're going to tell you their whole story, and you're going to be able to pick up where their concerns lie, and you need to give them those resources to allocate for them, that we're going to make this okay for you. And if we can't, we'll find somebody who can.
It's also amazing because people within themselves, they're not going to be able to tell whether they're having a bad day, whether they're deteriorating over a longer period of time. But someone on the outside that just maybe sees them once a month or once every couple of weeks, so they're able to see things that they themselves might not notice. So they're going to be like, hey, I'm doing okay. But a family member who's visiting is like, hey, Dad, last time you were a lot more chipper. You know, you keep getting a little bit further down.
Absolutely. And then we have our dementia and Alzheimer's patients. They can't communicate it. So you've got to look for their behaviors, because you'll find, if you're looking, you'll see it. And, you know, just one of the ways that I did advocate during COVID is I had a lady who moved her husband, who had Parkinson's, into what ended up being a long-term care place. And, you know, of course, people weren't going out and doing the assessments in person that was happening prior to COVID. So everything was, being done virtually, or we were faxing clinical and things like that. And I did not place this family, but they called me in the middle of their crisis. And this poor gentleman had been in this place for 2 months and had had 3 hospitalizations in a neuropsychiatric hospital. He was in the place for 5 days, okay? And I told her, well, we'll move him out, we'll find someplace better, we'll get him what he needs. And of course, there's a little apprehension, like, well, they promised me they're gonna get more staffing, and it's like, okay, but staffing issues don't generally correct themselves in 2 weeks. Of course, she went that way, and then of course my phone rang again, like, this isn't working. And he's back in the neuropsychiatric hospital. So what I did is I had them fax the clinical to me, and it was very easy for me to see what was happening. He was on a medication we call Haldol, and it's an anti-psychotic med. And he would get stabilized at the neuropsych hospital, and then they would send him back to the facility, and they would not give him his meds. They said he refused it, or they weren't giving it, whatever the reason was. But he didn't have any problem taking it at the hospital, which seemed odd to me because, okay, we got to figure out where's the disconnect. But I was able to realize what was happening to him is they would get him up to a therapeutic level, with his behaviors and things like that, with the Haldol. He would come back to the facility, they would stop at cold turkey. He was withdrawing from the medicine, which was causing the behaviors again, which he was aggressive, he was combative, and they can't have him here, and they're sending him back here. And it's like, okay, guys, but wait a minute. What if we start, titrating this medicine, backing it off a little bit, slowly letting him wean off of this? And then we try this again. Of course, not to that facility because they clearly couldn't handle it. And that was a case of they just took him to take somebody, right? He didn't belong there in the first place. We did that, and we've got him successfully placed, and he's doing great.
Wow. That's a heartwarming story. It's
there's I do this all day long. And that's the thing, like, I put my head on the pillow every night knowing I did right by so many people. And sometimes I'm like, can I get paid for this? Right. And that's the other thing I do want to say. Like, CarePatrol is a no-cost service to them. We do get paid by the communities and the home care companies. So it's not anything that they pay us for.
So how can someone reach out to you, Ruthie? They see you, they see you're genuine, you want to help, you know what you're doing, you have that clinical background. How can someone get in touch with you?
So they can go on my website at mokena.carepatrol.com. And they can also reach out, all my numbers are on there. I can give my office number right now, which is 708-377-9969. And, we'd love to help them. And, we understand it's scary, and we've been there ourselves.
Thank you. Thank you for joining us on the SNF Spotlight.
Thanks for having me. It was fun. It was.
The SNF Spotlight Series would like to thank the Renewal Rehab family for sponsoring this program. Renewal Rehab is the best therapy provider for SNFs nationwide. So if you're an owner or an operator of a skilled nursing facility and you want contract therapy, you are going to want to call and connect with Renewal Rehab. This series is geared towards highlighting healthcare leaders as well as healthcare heroes in the SNF space. So thank you all for watching and supporting this program.